Hi everybody, so my name is Tenille. I work at Peter Mac across the road, and I'm the manager of wellbeing and peer support at Peter Mac. So I'll just give you a bit of an introduction to wellbeing, so you have an understanding of the projects that we have in our team. But we operate under a wellbeing model at Peter Mac, which essentially means that we believe the best cancer care is treating the person, not just the disease. So we focus on the emotional, spiritual, cultural, and social aspects of the patient's life and how we can better support them to improve their adherence to treatment, just to improve their outcomes outside of cancer and not let their diagnosis consume them as a person. So our team actually has a wellbeing centre on site at Peter Mac at Parkville. And if you're ever around, you're welcome to come in and view the wellbeing centre and have a look around. Most of our projects, programs and services will run out of the wellbeing centre, and we do a number of different programs for our patients, but as well as friends, families and carers are a really big population group we work with as well. So the types of wellbeing programs that you might see in the centre that Peter Mac run are things from complementary therapies. So that is anything that is not essentially clinical. So it can be oncology massage, it can be art therapy, it can be music therapy. So we run these for our patients. We also have over 10 support groups, and they're usually specific to a tumour stream. So it would be the lung cancer support group, but then we also have population group support groups, so men's support groups and carers support groups as well. We also do a lot of research through our team as well, and the research focuses on the patient experience, but also staff experience. So I guess one of our big projects at the moment is where researching the staff experiences with the implementation of voluntary assisted dying in Victoria. It's been in place for just over 18 months now. We also look at the patient experience, and often we will implement new, interventions to improve the patient experience. So 12 months ago, we opened a palliative care ward in our hospital, and alongside that, we implemented palliative care volunteers. And this was a large project because these volunteers need a lot more support and training than your regular volunteers in the hospital. Outside of that, we have a lot of work that we do in the cold space, so culturally and linguistically diverse groups. So we have a number of support groups that are run by external organisations with us. So the Chinese Chronic Cancer Illness Society works closely with us. We have an Aboriginal Yarning Circle, which is a support group, and we also have Aboriginal liaison officers that are in our team as well. What else is going on? So that's, I guess, a bit of an overview of wellbeing and an understanding of how it fits into the medical model. Often we might be a step up or a step down from social work and psychology. Those type of services still exist in the hospital and we work alongside them. But if someone is regularly seeing a psychologist at the hospital and their next step is a step down, they might be referred into one of our support groups, for example. Or they might be picked up in a support group as high risk or very vulnerable because at home they have a lack of family support or they're facing financial hardship, and then we can refer them up to psychology or social work as well. So we sort of work as a wraparound service and in collaboration with all the other departments. In terms of projects and what we have going on, something that our team is really, actually before I go on, does anyone have any questions about wellbeing at all? So in terms of projects, our team is very passionate around helping our patients navigate the cancer experience. So we have a patient parliament where we come together once a year and all our patients basically have a chance to have a voice and talk about how we can improve the experience for them. And last year, patient navigation came out as one of the main themes. Patients have a number of difficulties and frustrations with the fact that cancer is a very complex diagnosis. You can be a part of one tumour stream or you can be a part of 10 tumour streams. Often patients don't know much about cancer and the treatment pathway before all of a sudden they're thrust into it, and usually with the diagnosis you will be in treatment the next day or that week. It is a very quick turnaround, and it's a lot of information to try and wrap your head around very quickly. So navigating the cancer experience is something that's been on our table for about 12 months, and we're trying to think of, I guess, innovative ways that we can support our patients to know what's going to come next. Some of the key things they said were they want a realistic advice. So often what they get from the oncologist is what will happen next, but they don't talk about the side effects that will be the most prominent, or they don't offer tips and tricks. A good example we have is some patients will go through their entire treatment not knowing about specific shampoos that actually developed for cancer patients that stop an itchy scalp. And the only way they find out is talking to another cancer patient in the lobby or in a waiting room. So things like that they completely miss out on in their cancer journey, and it could just help them alleviate some of that stress. So journey mapping, again, it has a few of its own challenges because, like I said, it's very unique, everyone's journey. It can go in any direction as well, but there is a service in the UK called PALS that we're really interested in modelling. So it stands for Patient Advice and Liaison Service. In the UK, every hospital that's part of the NHS, which is their public hospital system, is mandated to have PALS. And it can be someone with a background as just health administration. It could be someone with a qualified background in allied health or nursing. The backgrounds really vary, but the idea is that this service sits inside hospitals, and it is a point of contact that remains the same for a patient throughout their entire journey and is accessible. So often our patients will see their oncologist once a month or once every 6 months, and then they cannot get onto this person. You can't just email or call your oncologist, and the same with your surgeon. So we have nurse consultants at Peter Mac that are very busy because they're taking care of whole tumour streams. But in the UK, this PALS service has been very successful in supporting patients and family, and friends and carers can also ring the service as well. So they will link you in with information. They can help triage you to other support services. They're also across external services. So in the community, they'll find your local postcode and refer you to local services that you might need as well. So we've been looking at that model for quite some time and how we could implement something similar at Peter Mac. But there comes, funding and capacity around that. So we've taken it sort of to the next step, and we've been working with Shaitan on his PhD around wayfinding and looking at how maybe we could do a patient journey map type of, project. So that's our big one. I guess that's our baby that we're nurturing, and we really want to see that off the ground. But, we need to bring in stakeholders and have these kind of workshops and discussions about how we might do it. And then other than that, the other one I thought might be interesting for all of you is that at Peter Mac, we actually this year are reviewing our Welcome to Peter Mac pack that you get on arrival. And we are still paper-based on that pack. There is we don't have sort of any electronics or even a map that you can download off the website that shows you all of the levels and where you need to go. In terms of actual wayfinding in the building, it is very tricky. We have volunteers on the ground that help patients find their way around, but we are still giving out, a tote bag with information and printouts in it, and that's great for some population groups, but it does prevent us from being able to translate it, for example, into other languages and just have it readily accessible, especially for carers. If we're giving it to the patient, there's no copy to the carer and things like that. So that was the second sort of project that we're working on at the moment that could help, which could do with some help in terms of innovation and technology. And then something I thought would be interesting for you guys is that we sometimes we move forward in a really good way, and then other times we remain paper-based, but we've just implemented bedside terminals at Peter Mac on every single bed. And it was a huge project, and basically it's a really interactive bedside terminal. It's attached to your bed. When you are put into a ward, a volunteer will come along and they will help orientate you to this bedside terminal. You can do sort of everything from ordering your food on it to making an appointment with social work. You can do telehealth on it if you can't leave your bed, or if your local GP is back in your home community. You can do phone calls back to your family as well. So it's not just a simple pick a movie and order food. It does everything. It's really, really intuitive, and it's taken a long time to program it. So we are sort of moving forward in a really good direction in that way, which is exciting. And then other than that, is there any questions?
I had a question. So you spoke about how like a big part of your work is looking into the patient experience, and I guess for this project, we are looking at like the patient experience but in the emergency room setting.
Okay. Yep.
And I had a look around and just to look at different case studies of what has been out there, and there's been like really interesting cases like using a therapy dog to like improve that patient waiting time. Do you have any examples where there might not be traditional methods, like through your experience in the field? Do you know of any?
Yeah. Well, look, so first off, Peter Mac doesn't have an emergency room, so we don't have an ED, but I will answer any questions about it as best I can. We call those services complementary therapies at Peter Mac. We do have therapy dogs, which are incredible. We have 5 of them. They come in every day. They have their own day each, and they go across the hospital, particularly in the waiting rooms. A few things that we've noticed to really improve the patient experience, and you just have to bear with me, is a cancer hospital, and a lot of the work we do is in palliative care and end of life. So our Aboriginal liaison officers have downstairs in our lobby, there is a beautiful traditional Aboriginal cloak that you'll see that is made out of possum skin. It's the possum skin cloak, and that is used at end of life in the palliative care ward to make our Aboriginal patients feel closer to home. If they can't go home and die on land, then they will want to have this cloak with them. So that is something that we found out through engaging with our consumers, which is another word for our patients. So through that engagement process, and often we'll have a working group. So we have a consumer engagement committee. There's about 15 to 20. They rotate through, and they talk to us about patient experience. And that emerged from that committee was at end of life, those wards did not feel like a safe place for that cultural group, and it was an outcome of one of those findings. And then outside of that, what we are interested in is the way that cancer care in the United States is now using equine therapy. We're definitely not there, but it is a horse. The horses come into the hospitals. They're incredible, and probably definitely a level up from dogs. They are trained to not poo in the hospital. I don't know how, but they're trained to not do it. They come in and they go in the elevators, because obviously we have the huge elevators to move patient beds around so they can fit. It's pretty interesting. We are sort of just looking into it now, and we'd be excited to have something like that. But if you're interested in sort of those complementary therapies, we often look to the States and the UK at what they're doing and try and embed it into our services. I think our most popular is definitely the art therapy, our therapy dogs, and oncology massage, because that's a very unique service. There is cancer patients are often in a lot of pain in different areas, and they can't go to a traditional masseuse because there is an entire qualification and undergraduate degree behind oncology massage, and they're very rare and limited masseuses.
I don't have a question, but I think that it will be very interesting for them to know some of the techniques that you use for the national health standards would call consumer engagement.
Yes.
I call
Yeah.
these mechanisms in place because I've done some work with Peter Mac and Geraldine before, and I know that the Wellbeing Center in particular has created very user-friendly platforms for these collaborations that are not just a questionnaire or an interview.
Yeah. So we co-design every program, service, or intervention that we're delivering because they are for the patients. A good example is at the moment we're looking at a peer-to-peer sort of program where you can essentially, if you're a new patient and you're identified as vulnerable, we can match you with a peer that has a similar treatment schedule themselves, so they're a survivor of cancer, and they would essentially be there for you to support you throughout the journey and talk to you about what might come next and what it looked like for them. So to do that, we use a co-design approach, and because, as I mentioned before, we have a number of support groups, we actually can leverage these support groups really easily to access our engaged patient group, and usually those in the support groups, they're high enough need to be attending the support group. They're currently going through treatment and they have a genuine engagement and interest in what is happening at Peter Mac. So we do a number of focus groups, but they're less formal, so often very semi-structured. You'll have maybe 3 or 4 questions. We often view them as consultation workshops, but at the end of the day, through a research lens, it is called a focus group, and we'll do them in a number of series. So the key element of the co-design approach that we use is it's not just one consultation, it's usually a series of 3, and after each one you'll return in the next consultation and actually present what you've written or what you've put together from the first one, just to make sure you are on the same page as the patients. And once they acknowledge, yep, you've captured everything, or actually maybe you've missed this, it got said, I don't think it's on there, or I thought about it after I left the workshop. So we go back and forward a little bit until we get to the final stage, and we have a pilot model at Peter Mac where everything gets piloted for the first 12 months before we scale it up across more tumour streams. So our palliative care volunteers, they're a pilot at the moment. They won't be scaled up because obviously they're just for our palliative patients, but they are being piloted for a study because volunteers often in cancer hospitals are not specifically trained for a ward that they're on. They're just put through standard training. So we're trying to see whether or not there's an impact there.
So, you talked about telehealth earlier. I was just wondering, how about you sort of go to, you talked about sort of pilot studying, how you sort of try to get 12 months of trying to study a new thing. How do you sort of go about that? So, especially with telehealth, where it's so online based and less face-to-face consultation, how do you sort of set up those sort of studies?
Yeah, look, a lot of studies were put on hold during COVID for that reason. If it required a face-to-face collection of data, or if the study itself could not continue, it was put on hold because patients weren't coming into the hospital. Honestly, a lot were just put on hold, and a lot of patients moved to telehealth. And there is some big statewide research going on into the impact of telehealth and whether or not it's effective or if there's long-term repercussions from it. But ultimately, at Peter Mac, we've not done sort of any initial research into it in my team. It's something that we do have a sort of another team that handles telehealth and IT and whatnot that I have no doubt have probably looked into. But we have heard that for some patient groups it was incredible, it was really successful, and they'd like to continue that way. Other patient groups really struggled. As you can imagine, COVID was sort of 2 years of no patients, and in 2 years as a cancer patient you can go from diagnosis to treatment to recovery. So we actually have patients in those 2 years that never stepped foot in the hospital and are now in recovery, and they could do chemo in their home communities. But it's interesting to think that that is how that 2-year period works for some of our patients, whereas for others they will be with us for 7 to 8 years. It just depends. But yeah, sorry, I can't answer that one.
That's right.
Follow it up though.
Yeah. That's all good. I understand. I was just like, where he's mentioned it before, I was just like, sure he would.
Yeah. Well, telehealth, it did exist before COVID, so it was very much in place. It was just that we scaled it up very quickly and implemented it across the board very quickly. And I know for some populations that it ended up just being phone calls because the camera was just not something they could even get to work, which was even harder because you could see the clinician that you were talking to. And this is just anecdotal evidence that I have from working in the wellbeing centre where I have patient interaction every day and they come and talk to us. Another thing that I'm not sure if you're aware about, but there's the electronic medical record that went live across all 3 hospitals last year. And before that, we were all paper-based, so all of your records were under your name in a file in a cabinet somewhere. And all 3 hospitals at the same time went to the EMR, which has been a challenge, but now we're at a point where it's really, really good and it's working well. And we have patients come into the wellbeing centre and, you know, often they'll take a seat and they'll say, can you just help me with the EMR? It's called Health Hub is the name of the app. Can you help me with it? And I'll sit there with them for 10 minutes and just quickly show them. But yeah, you can now access all of your health records on an app called Health Hub. These are your health records from any of these 3 hospitals. And it's much more easy to access than my health record. Sure, but
Is there still some information that does not kind of get out there?
yeah. So there's break glass is what we call it. So information behind the glass cannot be seen by patients. There's also the cool thing about it is that if you have a carer, we can sign them up as your proxy so that they can actually access all of this information. I think it's really been life-changing for carers because often they can't get the information and they're the ones that need to submit it to the NDIS, or they're the ones that are coordinating all the supportive services. So now that they have what we call proxy access, it's a lot easier for them. They can print off blood results and get it taken to the GP with them, and that's been a lot easier for them. But yeah, the break the glass function will keep information being shared that isn't to be shared, and it's also a lot easier now for GPs to request electronic information from the hospitals. There's also a statewide mandate on family violence that was not ever previously in place. It was required, but it was never mandated. So now it's easier for hospitals to share information. So there's a family violence flag. It just means that this patient or carer or their family is flagged for that reason, and it can be shared across precincts and it can be shared back to the government when it is mandated by a court of law. Otherwise, it's confidential. But that has made it a lot easier because we do work closely with the Royal and the women, and we share a lot of patients as well. So the whole EMR has all these functions and it's brought everything together and made the working life of clinicians a lot easier. Sure.
So do you find like an online base in terms of sort of going, here's my sort of situation, that could be linked to sort of physical health, sort of helpful, so to have like online sort of, someone can just come in as anonymous and sort of input their sort of information going, this is kind of what's happening, this is kind of how I feel, and then that's kind of flagged, and hospitals and other such in-nurse and like clinics, can sort of find out through that, like is that
so it is definitely helpful. There's a security level on everything, so not everyone can see everything. For example, the psychologists and the oncologists would see the family violence flag, but the general nursing workforce wouldn't see it unless for a specific reason. So the whole thing is set up so that things can be seen and not seen to help that process, because sometimes too much information is actually not helpful, especially for the nursing staff on the ground when they have 30 patients and they just need to sort of know what they need to do here and now. So I think it's been helpful in both sharing the right information, but also withholding what doesn't need to be shared and not excessive for staff and clinicians.
Yeah, so it's about like information selection.
Yeah. Yeah.
I've got a question. You mentioned before about the horses,
Yes.
which is pretty cool. I was wondering if you've heard of any like rising like new technologies coming with other countries, like ones that you think could have implications, like AI?
Yeah, okay. So we have a robot named Temi, Temi. Temi was donated to us by a robotics company at the start of this year, and we're still working out what to do with Temi. So it's about this big, and it kind of looks like this thing here. It can move around and go about the hospital once the floor plan is mapped, is programmed. But Temi can't use the elevators, so it's a bit of an issue because we don't know how we're going to move it from floor to floor, and obviously can't use the stairs. At the moment, it's with our tech team off somewhere being programmed and having all the levers put into it. We're having general discussions at the moment. So it was donated to Wellbeing, which is quite cool for our team, but we just need to make sure we use it, otherwise someone will take it off us. But we're considering it just being available as a translation service for our patients. We do have interpreters that we can get in face-to-face or over the phone, but it would be so efficient if we had the robot that could translate into any language that you asked it to in a clinical consult, whatever it might be. Unfortunately, we're hitting a lot of barriers at the moment because words just do not translate. The word medicine might mean something completely different in another language. I think we tested it recently, and we asked it to ask for some medicine, and it asked, when am I going to recover, when we translated it. So we're sort of navigating that, and it might be that we use it in a different capacity, but we actually don't know yet how we're going to use it. Its main function, there's 3 in Australia, 1 in Brisbane, Adelaide, and 1 in a WA hospital. Their main function over there is that it visits patients in the room, and they can just use it to do as they please, like an iPad, I guess. They can video call family and friends and call back home and stuff like that. We can use it for that function, but it can do much more than that. It also has adaptation, like a sort of things you can put on the side of it that you can modify how it looks, is what I would say. And then it can go downstairs, and it could have a tray, so it could pick up food and it could take it to the patient's room and things like that, but it can't use the elevators, so that's really got us stuck. So we have a whole room downstairs full of clothes, shampoo, conditioner, all these things, because sometimes patients will come through Royal Melbourne ED and across to us and be with us for 2 weeks, and they have no idea, so they haven't even got a bag with them. So we have all that stuff with us at Peter Mac that we can give to our patients, and we have a wig library and all that kind of stuff. And we thought it would be great if they could ask Temi for things like shampoo and conditioner, and we could go get them. But the elevator has us really stuck.
I can't use the elevator. Is it like electronic? Sorry.
Yeah. It's just the electronics of it.
We may have something to help you out, by the way, which I'll tell you about later.
Yeah, cool.
Yeah.
I have a video. I'll get it sent to me, and I'll send it to you, Shaitan. And it is pretty cool. Like, you can touch it on the head. We call it the head, but you can touch it on the head, and it will follow you wherever you go from that point. And then you touch it again, and it will stop following you. It won't obviously run into walls and things like that. But another issue is we have all of these glass walls at Peter Mac, so it doesn't register them unless it's programmed with the actual floor plan. So hopefully we'll do something great with it. It's come from an Israeli company, and they use them in Israel in a lot of hospitals. Just working out what we can do. But other than that, I'm not really across too much. We focus mainly on our robotics in surgery. So I think we have 4 robots at Peter Mac overall, and most of them are, or all 3 of them are surgical robots except for Tenille.
Let's go. Thank you.
I'm curious about, like, Peter Mac is such a huge building, right? And then the new palliative care ward is there, which is kind of like as big as, but like, got
12 beds.
Small, yeah, 12 beds. What is the rest of the space?
I know, yeah, great question. So Peter Mac, ground level is general reception. From ground level up to level 7 is wards. So you have level 1 is palliative care ward, 2, 3, 4, 5, 6 are wards. So there's day therapy unit, chemotherapy, for example. There's a surgical ward. So when you come in and out of surgery, and there's some other wards, and they're just general wards. And then there is we have some patients need to go into airtight rooms. There's an actual medical name, I've forgotten it. We had to give those rooms over to the government during COVID actually because they were the only ones in Victoria. But we have those because our patients get very, very sick sometimes. And then above level 7, which is lecture theatres, goes up to level 13, and it's all research labs. So we have a couple of floors which are just research offices, and then from that point up, we focus really on clinical trials. So it's mainly fish and mice that you'll find up there, and our lab scientists working on clinical trials.
And that screen that's coming next to the bed,
Yes, the bedside terminal.
when is it expected?
Very soon actually. I think in the next 6 months. Yeah. So they've done everything, and now they're just training up we call them cancer scouts. So they're sort of about to graduate from an undergrad, usually in some health degree, and they volunteer as cancer scouts, and we're training them up to orientate the patient to the bedside terminal. Once they're trained up and they're allowed back in, but we still are limited visitors.
How big are those screen size wise? Like, are they iPad?
Bit bigger than iPad, yeah, but not quite laptop.
Okay, fine.
Just we'll stay in contact.
All right.
You'll have to come over and see them, but the health literacy manager, she sits in our team and she's heading this project up. So our team is really diverse in terms of the work that we're across. But anything to do with patient experience, so that's why it's fallen into our team, this project. But I can have Tenille come and have a speak if you want. Once they're up and running. Yeah, sometimes we move forward.
So would students be allowed to visit?
When the restrictions completely lift, absolutely. Yeah. So I don't know when it'll be. We're still limited, but it's not. It won't continue for much longer. I don't think. You just show your vaccination status and check in, and then basically what we do is we'd set up a process. You just need to identify a staff member. So in this case, it would be me. You would be my guest. I would check you in downstairs. We can go to the wellbeing centre. We can go to the wards. We can have a tour. We can have a look over at palliative care as well. It's a really interesting space to have a look at and just ask questions. Obviously, we're a research institute, so we have students through all the time. We just you just need to nominate who you're visiting and have a student ID if you've got one handy. And sort that out.
And do you still have the youth center?
Yeah, on track.
Yes,
Yeah.
I think that space would be really good for students.
Absolutely.
I find something fascinating about Peter Mac, and that's something that maybe you all and Peter Mac take for granted, but it's the role that design plays in well-being and patient experience. I really like the well-being, how it is almost like an oasis in the middle of a hospital.
Yeah. If you visit the centre, you'll see it's a soft space with a lot of lounges. There's usually music playing and diffusers going. We don't have a television in there. Quiet space. There is a music room though if you want to play music. So it's a beautiful space. If I had a presentation I'd show you, but yeah, On Track is for the youth. So it's almost the wellbeing centre, but a version for youth at Peter Mac. And it was donated by Sony when the building opened. So it's a lot bigger than the wellbeing centre. It's decked out with everything. There's a soundproof music room with every instrument you can imagine in it. A huge TV, a kitchen, and a study space for students that are coming for treatment during school hours and things like that. There's as well. It's not as used as ours because we don't have that many patients that are pediatric patients, and a lot of them don't want to spend time in hospital. And they go home. It's a great space.
Was the time when the government was encouraging hospitals to kind of design spaces within or have designers working in healthcare spaces? Was that something that happened at Peter Mac or how? Is your engagement with design like how does?
Look, I don't know if I can answer that one. I've been at Peter Mac for 3.5 years, and we did move over from the old site. If you're ever in the city, you'll see some really old buildings near gardens that have Peter Mac written on them. I don't think there's anything in them now. We were there, and maybe 7 years ago, I think we moved to Parkville. So I'm not sure on the design and the build and things like that, but it was a complete new build, and it would be about 7 years. So it's a very new building. But there's still levels on the hospital that are not refurbished, and we just do them as we need them. So at the moment, level 9 is under construction because we need more space. So they opened it as soon as they could, and it was just a case of as you grow, we'll furnish more places. No, I should know that one.
Great. So that's really wonderful, Tenille. And you kind of talked about 3 projects which the students can come on to. We have the videos so you guys can revisit it if you want, and then we can come and speak to you about it at the later stage as it comes along. Any last questions for Tenille?
I might have one. It's not fully formed yet. Okay. I was wondering, because when someone is going through cancer, of course it's different depending on their stages. How does family involvement? Pretty sure there's a group that's supported at one point. But what happens, for example, they're adult and they have kids, and I'm pretty sure that responsibility of going to the hospital is also divided to wanting to spend time with family. I don't know, does Peter Mac try to have that family involvement as part of
Yeah, so I guess it's tricky to answer. It's hard at the moment with COVID. So, for example, you are usually only allowed to have your primary carer with you in an appointment. But there's situations where there is not a primary carer. There is 5 people around this patient who identify themselves as the primary carer and want to be involved in treatment. It's actually, so we do everything we can to support the whole family, and we will write letters and we will advocate and say this is why they need the family in there. We have the Wellbeing Centre open outside of hours sometimes for families so that they can sit in there and go in one at a time, because you are allowed one at a time. But I think, what we would really talk about there is advanced care planning is what we talk about in cancer care, where the patient themselves needs to, as early as they can at the point of diagnosis, we hope that they will do an advanced care plan and identify who is making these primary decisions for them and who is the primary carer, so that we can help support them through the process as best we can, because if it does come to end of life and that person is not identified, it can be quite messy, and we do need social work involved to support the whole family in those situations. But it is so hard to have that conversation with a newly diagnosed patient when they're not ready to accept what's happening, let alone write an advanced care plan. So it's a very interesting space that we often navigate, but we focus on, supporting our carers as much as we can. They're really underserved and they take on such an emotional burden. Well, we don't like to use the word burden, but it is an emotional challenge for them. So we offer, little camps and things where patients can go away with a medical team to go camping or something for the weekend for respite, and carers circle and just a number of other programs we can link them into. And it's actually been a focus a lot more in the last 2 years. And the state government has put a lot more money into funding carer roles at hospitals. So we now have a carer liaison officer. She sits in the wellbeing team with us, and she started about 2 months ago. And she's already very, very busy supporting carers, which is usually a family member. Yeah.